Good afternoon to all, and good morning to our colleague from outside Asia. Today we have our first series new session of Fujita Bantane IVR web seminar with other institutions. And this time we have our first session with Kazakhstan. And before we start our session, probably we can hear a welcome address from Professor Yoko Kato. Professor.
Hi, welcome all of you. Thank you very much for joining the first one of the Fujita Bantane, the endovascular, the webinar. So today we have two big experts, the talk. So very much looking forward to this event. Thank you very much.
Thank you, Professor Yoko Kato. So without any ado, I would like to introduce two speakers of today. First is Professor Kenichi Haraguchi, who is a Senior Assistant Professor from Department of Neurosurgery, Fujita Health University Bantane Hospital, Nagoya, Japan. Today he speaks on endovascular treatment of intracranial aneurysm using transradial approach. Our second speaker is Professor 𝑫𝒊𝒔𝒂𝒂𝒏𝒕𝒂𝒔, who is a Vice President of the Presidential Hospital Astana, Kazakhstan, who is also a Vice President of National Medical Association of Kazakhstan. And today he will speak to us on endovascular management of intracranial stenosis. Our chair is Professor Zubin and Professor Yoko Kato, and we are honored to have Dr. Aya Hashimoto, who is Assistant Professor from Department of Neurosurgery, Kurum University Hospital, Kurum, Fukuoka, Japan, joining us today as a discussant. So without further ado, I would like to call upon Professor Kenichi Haraguchi to give his lecture. Professor, please.
Hi, good afternoon, everyone, and thank you for introducing me, Dr. Liu. So today, I have a presentation about the endovascular treatment of the aneurysm using the transradial approach. So I'll share the slide. Is this okay? Okay.
Okay.
Full screen. Yes. Okay.
No, yes. No, yes. Okay. Okay. So this is introduction. The radial approach. The largest advantage of transradial approach is fewer complication about the puncture site, and it also allows area ablation, and the patient is so comfort after the procedure, and also it's cost effective. So this is a rate of the entry side complications. So in this study, in transradial approach, the complication rate of the puncture side was 0% compared to the femoral artery access of the 2.0%. It includes puncture site hematoma or dissection or vascular repair. So this is the summary in our hospital in this 6 months, only 6 months. So about the approach site. So the most of all procedure about the aneurysm treatment is performed via the transradial approach. There are about 65% of cases try to do the discharge transradial approach, but some of them we failed and converted to the conventional radial or femoral approach. So this is today's menu. At first, I speak about the anatomy and puncture and pitfalls. And next, I will speak about the approach to the cerebral arteries. So this is the anatomy of the radial approach. Distal radial approach, radial artery, and conventional radial artery. So we usually puncture inside this triangle. So this triangle is called the anatomical snap box. So it's surrounded by the tendon of extensor pollicis brevis, extensor pollicis longus, and trapezium bone. So inside this, you can touch, you can sense the palpation of the radial approach, radial artery, and you can puncture this artery. So this artery is a distal branch of the main trunk of radial artery. So, and this branch is called deep palmar branch. So this is the paper about the deep palmar branch, deep palmar arch of the radial artery. So in this study, they investigated the palmar arches of the superior side and the deeper side. So in the superior palmar arch, so 46 cases of the patient, it was incomplete. And whereas the deep palmar arch was complete in the 100% cases. So we use the distal transradial approach first. So this is the picture of the puncture. So I designed the two tendons and the snap box, and this dotted line is radial artery. So either ultrasound guide or sensing method is okay, and I prefer the sensing method, but either is okay. And the key point is ulnar flexion. So by doing this, you can palp the distal radial artery well and makes it easy to puncture. We use a log-shaped towel under beneath the hand, neck, the wrist. Ulnar flexion is very important. So after that, we insert. This is the protocol of the inserting the Cs. At first, we insert the 4 French Cs shortly, and after that, we do the angiogram. And after we inject the 200 micrograms nitroglycerin, and sometimes it dilates the radial artery like this, and after that we extend the guide the Cs, 4 French Cs, to the guiding Cs. So this is pitfall. So this surgeon is trying to go to the distal side, but the guide wire stucks around the elbow. So, and in this situation, the angiogram revealed the extravasation here, and So it causes a big subcutaneous hematoma. So you have to check the angiogram at first and take care not to insert the small artery, or you have to do the gentle manipulation. So in this case, the migrated artery is called recurrent radial artery. So this is very, very important pitfall. So this recurrent radial artery branches from the proximal side of the radial artery and goes retrogradely to the proximal side. So you have to know this artery and take care not to insert the guide wire to here. So next is the approach to the cerebral arteries. So this is the most frequently used guiding catheter in our hospital, called wrist. It's sold by Medtronic. So this is made for radial access, and this catheter has a flexible distal zone, long length of the flexible distal portion. And this is this video is a standard approach procedure to the left internal carotid artery. So at first we insert the Simmons-shaped catheter. This Simmons-shaped catheter is attached to the wrist system, wrist guiding sheath, and you insert the guide wire into the internal carotid artery. So in this guide wire, this guide wire is a half stiff type, not a normal type, standard type. In this wrist guiding catheter, the half stiff guide wire is recommended to use, and we push the wrist catheter like this over the first Simmons catheter. So here you can see the tip of wrist guiding catheter inside the distal ICU. So also this is a pitfall. So especially in the left side aneurysm, left side region, it has a risk of slipping down of the this catheter, because this wrist is a very soft, long tip catheter, and it is a little weak against the strong, hard devices. So this is a web case. So we are trying to insert the microcatheter. This is a via microcatheter to insert the web device. And here you can see the aneurysm, and the guide wire, micro guide wire is inserted to the aneurysm. And when we push the support balloon here, the wrist catheter dropped down from the first position, like this. And sorry. Yeah, wrist catheter is dropping down. And here we inserted the web device. This is the tip of the web devices. And we use the support balloon inside the internal carotid artery. But during this procedure, the guiding sheath, or wrist guiding sheath, dropped down more in the more lower position. And after that, we wanted to push the web device, but at that time, this balloon catheter shifted downward, so we noticed that the wrist catheter dropped down like this inside the aortic arch. So this is a very important pitfall. In this case, we converted to the femoral approach. So this is because of the softness of the long distal portion of this catheter. So it's important to insert enoughly distal to the internal carotid artery and place the hard proximal portion over the aortic arch here. It's important. So this is the other case. The other method to complete the left side aneurysm treatment is using stiff guiding seals. So we usually use the 𝑃𝑟𝑜𝑓 guiding seals made by the sorry, I forgot. 𝑃𝑟𝑜𝑓 is Medicos Hirata Corporation. So this seals is hard compared to the wrist guiding catheter, so it has a very strong support. But of course, this is a lower navigability compared to wrist catheter. So in this case, we successfully inserted the web device using the with a balloon catheter under strong support using this 𝑃𝑟O𝑓 guiding seals. Yeah, this is the other method. So this is the case summary in our hospital. The most of the cases is treated by flow diverter, and the about 20% is web cases. In these cases, the crossover rate to the femoral artery is 6.8%. And in this 6.8%, the target vessel was all in the left ICA. Right ICA, bilateral vertebral artery regions, we successfully inserted the guiding catheter in all cases. So the failure is in all left ICA cases. In the left ICA cases, the failure rate is 16%. And furthermore, I classify the aortic arch type in these failed left ICA cases. The case number is 31 cases, and the bovine type aortic arch was 4 cases, and in 7 cases, it's a semi-bovine, and the standard type was 20 cases. And in this study, the bovine and the semi-bovine arch is all succeeded in our cases. So all access failure is all access failure of the transradial approach is the region in the left ICA and the standard aortic arch. So in these 20 cases, I took the picture of the aortic arch like this, and the success in this 20 cases, sorry. In the standard arch type, the success rate is 75%. So, among these 20 cases, the 5 cases were failure cases. So, this is a comparison of the success 15 cases and failure 5 cases. So, by comparing these pictures, so difficult arch is has a parallel brachiocephalic artery and left common carotid artery, like this. And also the type 3 arch. Type 3 arch is also difficult approach reason. And also I compared the mean age of these cases, and the higher age was also the difficult approach. So the reason of this age is maybe due to the hardness of the artery, I think. So in conclusion, in the transradial approach, you have to understand the anatomy of the radial artery, and you have to do the gentle handling. And you should take care not to insert the guide wire into the recurrent radial artery. In the approach, the all failure by a transradial approach occurred in the left ICL region cases. In such cases, the another method is using stiff guiding seats, and switching to the transfemoral approach may be necessary depending on the condition of the aortic arch. Thank you.
So Dr. Liu, unmute, please.
Yes, thank you, Professor Haraguchi, for your lecture. Probably I may start first a few questions for Professor Haraguchi. Professor, thanks for enlightening us on this new assess, which seems to be very good. I have observed few of your procedure there in Bantane. May I know that is there any different or possibility to have a left radial access rather than just right radial access? And could you be able to tell us what are the differences, whether left or right, whether the difficult case that you have shown us, if we have a left access would be easier or would be the same result? My first question. My second question, Professor, how far do you think that the preoperative imaging or ultrasound, linear ultrasound that used for the access will be able to tell us the possibility of cannulating the radial artery? Thank you, Professor.
理解できなかったんですけど。So, sorry. So, once more, please, and slowly.
Yeah. The first question is, I believe that you're talking about right radial access. How about left radial access? Is it possible, especially for difficult case that you show that unsuccessful case that you use right radial? If you use left radial, would it be different? And what are the difference between left and right radial? My first question.
Yes, yes. For first question, it depends on the cases, and it depends on the anatomy of the aortic arch. So of course you can use the left radial approach in the for the left vertebral artery lesions or basilar artery lesions. Yeah, of course, we use the left transradial approach for left vertebral artery lesions, but I think it's difficult to use the left radial approach for the left internal carotid artery lesions because it is more a sharp angle approach compared to right radial approach.
Okay, thank you, Professor. My second question, Professor, how much the preoperative imaging of be able to predict the success rate of cannulating the right radial artery for intracranial lesion, Professor?
So you mean the how do we assess the access route?
Yes, whether we can do a pre-procedure assessment that this cannot be using radial or this can be using radial, for example.
Basically, in all cases, we try to do the transradial approach, right transradial approach, and but in special case, so for example, the brachiocephalic artery and left common carotid artery are long and parallel, or the severe type 3 arch, we sometimes select the transfemoral approach from first time.
Thank you, Professor. Maybe we can open to Professor Aya. Any question from you, Professor?
I have one question, okay?
Yes.
Okay. Do you perform this radial approach for thrombectomy?
No.
No.
Not so far. Not yet. Not yet. So because the thrombectomy needs a shorter time. It's if you fail to access via right transradial approach, it takes too long time. So we select the transfemoral approach for the thrombectomy so far.
Oh, yes, thank you. Really, actually, so puncture radial distal radial artery. What time longer?
Compared to the femoral approach?
Yes.
It's the same. It's the same. It's
same. Okay.
Yeah. Maybe the learning curve exists, but in our experience, the in 20 or 30 cases, the approach puncture time will be the same as the femoral puncture.
Thank you.
Probably yes, there's an audience. Yes, you may ask question.
Dear colleagues, yeah, thank you so much for wonderful presentation, Professor Haraguchi-sensei. Yes, I have a question, but my question was already asked, and I have a next question about is there any applicability or using in pediatric patients, like? And the second question is there any data on long term, like using a radial artery following in the using in the neuroendovascular procedures, like after repeating some time, like after several months? Thank you.
Sorry, we we don't have the pediatric case yet, but I think it's very difficult to use the transradial approach in the pediatric patients because it's very small. Even in the adult or female, it's sometimes difficult to sense the radial artery. So in our experience, in the case, we cannot sense the radial artery. It's impossible to puncture even we use the ultrasound. So I think it's difficult to apply in the pediatric patient. So, and second question is sorry, I forgot.
Long-term, like repeated interventions.
So in our experience also, so it's in almost case it's possible, no problem. But maybe about 3 to 5% in the especially young female patients is the palpation of the radial artery gets weaker in the several months after the procedure. So no data. We don't have so special data. So, but I think in almost case it's possible to puncture repeatedly.
Okay. Thank you so much.
Yeah. Probably last question, Anyaku.
Yeah, thank you, Professor Haraguchi, for this wonderful presentation. Please, I was looking.
Thank you.
Are you hearing me? Are you hearing me? You're
Sorry?
hearing me, sir? Are you hearing me, Prof?
Yes.
Okay. Please, I was looking at the conventional radial artery and then the distal radial artery. So what informed the choice of that distal radial artery in place of the conventional? Looking at the conventional radial artery appears wider, easier to cannulate than the distal radial artery. Why the choice of the distal? And the distal radial artery is convoluted because of it passes through the anatomical snub box. What informed the choice, the distal radial artery in place of the conventional radial artery, that the proximal radial artery? In the complication profile, yes, the distal radial artery appears has a better complication profile than the conventional radial artery. So what really informed the choice of the distal radial artery in this procedure? I don't know whether
it's by the paper. It's not by our experience. The occlusion rate is different. The long-term occlusion rate is higher in the conventional radial artery. So this so as I showed in my slide, the distal radial artery can be occluded, but it has no problem. But if the main trunk of the radial approach is occluded, it may be cause a problem. So that's the reason we select the distal radial approach.
Yeah, thank you so much. Thank you, Prof.
Thank you very much. Thank you, Prof. Haraguchi.
Dr. Liu, maybe we can take a question from our comment from the Mingilji from the Kazakhstan. Any comment, please?
Hello, dear colleagues. Hello, Professor Yokakata and the presenter. I think the radial approach is the future, but everything depends on Japanese companies working on access devices. I know the Japanese companies is the best one, and for the radial approach with the different aortic arch, we are using destination catheter. And I think it's one of the best one, but it's quite stiff one. But for the carotid stenting, it's very supportive. And as I see, there is a 20% of 25% of failure, but with the wrist catheter, it's the next generation of Envoy catheter. The support of the guiding catheter is quite low comparing with the coronary guiding catheters. And this radial approach is developed and mostly used for the interventional cardiology, and interventional cardiology devices is the best for these approaches. I think the narrow catheters like Fubuki or Envoy or wrist catheters is less adapted for the most support. And when you use 7 French guiding catheter, might be used distal access catheter 5 French, but for most of the cases, I think it's less suitable. But for the patient, is very good approach. And after vertebral artery stenting in our hospital, patient just after procedure went for smoking. And with femoral approach, patient should lie on the bed. And yes, it's very good job, and you are changing the future. Thank you.
Thank you, Professor, for a nice comment. Professor Kato, you have any comment from your side? No? Okay. So we may proceed with our second speaker, Professor Bozinski, who will talk on endovascular management of intracranial stenosis. Professor, please.
Okay, just a second. I need to share my screen. If your technical team may help me, because this Zoom is a little bit changed, and the interface is okay. I see. Just a second. I hope you can see my screen.
Yes.
Okay. Is it okay?
Yes, good.
Okay. Thank you. The most experience presented in this presentation is the experience of Almaty City Hospital, medical center of the Presidential Affairs Administration, and intracranial stenosis and occlusions. I will talk on occlusions too from point of endovascular treatment. This is my disclosures. When we start to talk about intracranial stenosis, first of all, we mention about SAMPRIS trial. It was a negative trial, and it shows that best medical treatment in 30 days has a best result comparing with the angioplasty and stenting. And more than 450 patients was enrolled in this trial, but then some parts in this trial was changed in the future devices. The first of all, the device from Boston Scientific was adapted for the intracranial stenosis, but it's not the best devices. And to place these devices along 3-meter exchange wires needed, and exchange maneuver caused some intracranial bleeding. It's the first part. The second part, in this trial, the basilar artery stenosis also was at the same box with other intracranial stenosis. That's why the complication rate in the mid-basilar or distal basilar segment with the good angioplasty usually followed with the perforator territory strokes. And in basilar territory or M1 segments stenosis, if you do 100% nominal diameter of the artery angioplasty, at most of the time it could end with the occlusion of lenticular-striating artery or perforating branches. That's why this trial has some negative points, but this trial changed a lot. And in Europe, if patient has no strokes, then interventional neuroradiologists and I think in United States, neurosurgeons could not receive these patients because all these patients treated with the best medical treatment with the neurologist, and they're waiting for 2 strokes in Germany. And just after 2 strokes, interventional neuroradiologists can treat these patients. And in Kazakhstan, we a little bit changed our practice, and thanks to René Chapeau and my teacher Shimon Maimon also from Israel, we start to treat these patients. In the last 9 years, 253 patients, mostly males, and in Kazakhstan, they are smokers, they have atherosclerosis, they have diabetes mellitus. That's why mostly involved in this group male population, and mostly it's a middle-aged and elderly patients. And important point is the location of the stenosis. And if you can see this table, the basilar artery stenosis, it's mixed. It's a proximal basilar, mid-basilar, and distal basilar, but most of the time, half of the cases, it's a proximal basilar and the mid-basilar, and less distal basilar. And M1 segment, also the M1 segment, not all the time risky, because the position of lenticular-striating artery also affecting the treatment effect. If lenticular-striating artery coming from the stenotic segment, then we nowadays choose self-expandable stents. If lenticular-striating artery is distal from the stenotic segment, then it's possible to use balloon-expanded stents. And if you count basilar and MCA territory, it's total 22% of the cases could be risky territories, but in total, it's less because proximal centimeter of the basilar artery has no perforating arteries, and M1 segment not all the time has lenticular-striating arteries on all course. Sometimes it's in proximal part, sometimes in distal, but it's not all the time the same M1 segment and basilar in each patient. The other territory, V4 segment, it's frequent. The ICA territory nearly has no perforating branches. That's why that territories are very safe for the intracranial stenting. In total, we performed 318 angioplasty and stenting in 250 patients. This is additional information. 78% of patients had stroke, and 16% of the patients had previous intervention in extra intracranial territories or aneurysm treatment. 98% of the patients had hypertension, half of them diabetes, 1/3 had coronary disease, 1/4, 25% after myocardial infarction was done bypass of stenting. 67% of them had a hypercholesterolemia, and 72% of them was active or in the past or present smokers. And it's very important in our hospital in Astana. we start to do screening for the patient with diabetes, with coronary anamnesis, and if patient has a hypertension. These three factors, and additionally smoking could be added for this criteria, and patient in this group has a high chance to have a extra intracranial stenosis, and we have a population for our hospital is 30,000 population, and last year we diagnosed more than 100 patients and treated them for the extra intracranial stenosis. This is a kind of stents. I think it's not so important. Self-expandable and balloon expandable stents used. Antiplatelet regime is changed for last 6 years. Since 2019, we start to use very final aggregometry system, and total resistance in our population 22%. Mostly it's a clopidogrel 21% and 1% in ticagrelor patients. We still checking aggregometry in ticagrelor population. Sometimes patient has resistance in ticagrelor also. And nowadays we more and more using mono disaggregation with the clopidogrel if it's effective, or ticagrelor, because most of these patients has a gastric problems, gastric ulcer. That's why the mono disaggregation without acetyl salicylic acid is very important. Total complication rate is nearly 7%, less than 7% in total. It's an intraoperative and postoperative. Postoperative is mostly human factor. Patient stopped take medication, or it was a resistance for Plavix, clopidogrel, and most of the time on day number 5 after treatment, patient had a stent thrombosis. Postoperative and intraoperative also mostly ischemic complications. MRS was 1%. Control neuroimaging CT angiography in 1 or 3 months, and then in 1 year we are doing control angiography to decide for any additional treatment. This is a case of proximal vertebral artery stenosis, stented with a Protégé self-expandable stent. It was a kinking also. Then we straightened the kinking segment, and we placed self-expandable Aclinoflex stent in basilar artery through the narrow speed balloon. It's a Acandis product from Germany. It's very effective. And this case, patient was treated previously in different hospital. The stent in left vertebral artery was placed, but stenosis in basilar and right vertebral artery was left, and patient was on best medical treatment. It was not effective, and we suggested to treat the right vertebral artery stenosis with the balloon expandable stent, and basilar artery stenosis with the self-expandable stent. The similar patient treated for both stenosis in basilar and vertebral artery. Vertebral artery stenosis stented with the coronary stent. Usually it's Ultimaster from Terumo. Nowadays it's Nagomi. The previous years we used Tansei, and in basilar artery it's Credo heel stent. This is a treatment result. And in basilar artery, we are doing undersized angioplasty. It's all the time less than 0.25 millimeter. In some cases, we are leaving 0.5 millimeter from the nominal diameter, and it's very important. It's preventing rupture of the artery. In some cases, it's a calcified plaques, and is most of the time could be ruptured and may cause the bleeding. And it's also the prophylaxis of perforating branches occlusion. M1 segment, this stenting was done before the self-expandable stents was available. Nowadays, this territory we use mostly self-expandable stents. It was 𝑢ltimaster stent from TERRANSS, and this is vertebral and basilar artery stenosis. And this case with chronic occlusion of the basilar artery, asymptomatic, surprisingly, and the right MCA territory was symptomatic. And we decided also there is a microaneurysm on the ACA, A1, A2. First of all, we did angioplasty and stenting with a solitaire stent for 20. It's a very nice stent for thrombectomy, and it's also a very nice stent for angioplasty and stenting. And solitaire has quite nice radial force, and we placed solitaire, and patient was treated for ACOM aneurysm and MCA stenosis. You can see on the follow-up, it's quite good result. And also, since 2015, we start to stent occlusions. This is a both vertebral artery occlusion. We did recanalization with narrow speed balloon together with a coronary wire, and placed after angioplasty credo heel stent, and vertebrobasilar symptoms resolved after stenting. The other case, both vertebral occlusion with the vertebrobasilar symptoms. Right vertebral artery was recanalized with the narrow speed balloon with the Xeon blue from Akandis coronary wire, and the narrow credo heel stent was placed. And this is final result. And this is other case. The right vertebral is patent but hypoplastic, and the left vertebral was occluded. We did angioplasty and stenting for the left vertebral also. This is an old case since 2015. We did a recanalization and stenting for the occluded. Both vertebral was occluded, but we did the recanalization for left vertebral artery. And in this case, at that time, the credo or cleaner stents was not available, and we placed old version of pipeline stent, and it worked very well, and the patient had the improvement in vertebrobasilar symptoms. The ataxia was resolved in this case. And we had also complications. This patient was treated for critical symptomatic stenosis of the right ICA territory, supraclinal. The ACOM was not patent. The PCOM was also not patent. And we placed 2 Aclinoflex stents through the narrow speed, through the microcatheter with the coronary balloon previously angioplasted. And on day 6, patient was discharged on day 5, and day 6, patient was hospitalized in emergency hospital. It was a stroke symptoms, and we called the patient to our hospital, and the stent was occluded, thrombosed, and we decided to do stentectomy, and stents was ectomied, but then we decided to place solitaire stent, which was used for the stentectomy, and then because of the thrombosis, it was a decision to place a bypass. And this is angiography after bypass. Bypass was patent, and the solitaire stent was also patent. Patient discharged after 8 days after bypass. And we are following this patient. It's more than 1 year, and patient is asymptomatic for this lesion. And the other patient with proximal basilar stenosis with ataxia after stroke, it was on clopidogrel time, and we did a loading dose, and we placed 𝑢ltimaster stent, and on day 5, patient was comatose, and the stent was occluded because of the resistance to clopidogrel. It's a fluctuating effect of the drug, and we did aspiration and the stentectomy with the solitaire. And we left basilar artery after angioplasty, and patient decided to not to have a second treatment, which was recommended after a couple of months after this stentectomy, and was discharged with the improvement. And if you have any questions, I would love to answer to your questions, and thank you for your attention.
Thank you, Professor, for your great lecture. Probably I will start the question first. I have three short question, Professor. In terms of symptomatic intracranial stenosis, is there any algorithm that we can use to decide whether bypass, either direct or indirect, or stenting, which one to choose? My second question, Professor, in cases, elective cases of intracranial stenosis, what is the role of a contrasted MRI? A contrasted MRI is mandatory to do in terms of assessment of the plaque? Last question, Professor. In a patient who post-treatment of intracranial stenosis, do you think that long-term statin will help to prevent recurrence, especially those with normal cholesterol level? Thank you, Professor.
Thank you. It's a very good questions. I will start with the statins, and we are giving statins for those patients in all cases. If the cholesterol level is normal, even with normal cholesterol, we administering statins for lifelong, but patients usually complaining after 3-4 months for the pains in region of liver, and then we are doing pause for months or couple of months and then continuing again. It's about the statins. About MR, usually we don't do MR. CT angiography is enough in most of the cases, and it's possible to see the calcified plaque and the soft plaques also. It's a question about MR, but if patients have done the MRI, usually it's not contrast enhanced. It's usually not contrast MR angiography. And about bypass, yes, we had a previous experience with bypass. And if there is a stenosis in the question of occlusion, in nearly all of the cases, the bypass is patent during the follow-up. But in stenotic cases, in M1 segment usually, at the previous times, till 2018 to 2019, we recommended to do, before self-expandable stents was available, we recommended to do bypass. But during the follow-up, most of those bypasses are occluded. I think the concurrent flow from the stenotic segment, if the artery is not going to be occluded, usually bypass is occluded. And most of the time it's a 𝑆TA-MCA bypass, and it's not patent in most of the cases. That's why we changed our practice, and we are doing mostly angioplasty and stenting.
Thank you, Professor. Professor Aya, any question from you?
Thank you for your nice presentation. I always think that surgical indications for intracranial stenosis are very difficult. I have one question. How do you decide on strategy, PTA only or PTA and stenting?
Thank you. It's a very good question. And nowadays in coronary practice, it's also changing. And there is experience in non-STEMI patients without myocardial infarctions, without elevated T. Our colleagues start to use drug-eluted balloon, and it shows in long-term very effective result. And we have a couple of cases. It's just the beginning. we start to use drug-eluted balloon, and now we are following those patients. But in previous experience, all angioplasty was followed with the stenting.
Thank you.
Thank you.
We can open the floor for other questions. Anyaku, you have question from you? No question from you?
Thank you. No question. Thank you, Professor, for the presentation. I so much appreciate. Thank you.
Can I ask one?
Yes, Professor.
Thank you for a very good presentation. So, I think the coronary stent is a little hard for intracranial stenosis. What system do you use usually? For example, the distal access catheter or a guiding catheter?
Yes, thank you. That's a very good question. And as I said before, stenosis is a business of cardiology, interventional. And nowadays, we're using, in most of the time, it's a coronary guidings from Asahi company. It's a Hyperion guiding catheter. And we're just modifying the tip of the Judkins Wright catheter, and it has very good support. In ICA territory, it's a 8 French guiding. In basilar artery, in vertebral basilar system, it might be used 6 or 7 French guiding catheter without distal access in vertebral basilar. There is no need for distal access for vertebral basilar system. Usually the artery course is quite straight, and it's possible to place coronary stent from distal basilar to any segment of vertebral artery. And for the ICA, the anatomy is very important. If the cavernous segment has the anatomy like this, it's going distally. I prefer to use a self-expandable stent because this anatomy it's not allowed me to push the coronary stent. If the cavernous segment anatomy like this, and the wire and the stent could be sent directly, then it's possible to send the coronary stent without any distal access catheter. That's why nowadays we have a self-expandable stents, and we can choose with the anatomy of a cavernous segment which stent is better.
So you mean the self-expandable stent is a wingspan?
In Kazakhstan, we have Credo Hill stent from Akandis. It's specially designed for intracranial stenosis. It's like an enterprise stent. The design of the stent like enterprise, but you can send this stent through the 17 microcatheter. And there is another stent, Pegasus HPC, came from Phoenix company. Nowadays, it's a Valabi company from China, but previously it's a German company. It's also laser cut stent like a Neuroform Atlas, but specially designed for intracranial stenosis. The both stents available in Kazakhstan, and in some cases, it's possible to place flow diverter stent like Pipeline or any other flow diverters, or it's possible to place Elvis Evo stent or Leo plus Leo baby stents. It's also working very nice in intracranial anatomy.
Thank you very much. It's very good. So the only stent we can use for the intracranial stenosis in Japan is wingspan. That's the big problem in our country.
Yes, it's a problem of registration, and when we start to do PhD work of our colleague Marat Sarshayev in Almaty, his work dedicated for stenosis extraintracranial, and there is a lot of publications on enterprise stent, on the balloon mounted stents, and it's just needed big trials, and I think after that trials it could be possible to use any stent in Japan also.
Thank you.
Thank you. Professor Sarik, do you have any question from your side?
Hello, Professor Yogakoda. How are you? Thank you so much for our brother Munjaka conducting a very nice, excellent presentation on intracranial stenting. Because intracranial stenting is a difficult procedure. It is also on trial for many international trials. So I heard his lecture and inspired a lot. Because sometimes we have some patients for bypass, but the patency of bypass is less than 50% after a long time follow-up. So recently we are also followed Munjalka's opinion about this intracranial stenting. So we also conducting some trial to introduce intracranial stenting. But I heard one question is a very simple question. You introduce maybe as a new terminology, stentotomy. It just means remove the stent using a solitary stent, if I understand it.
Yes,
So
thank you.
that's my
Thank
question.
you, Professor Sarik. Yes, it's not new. It was a publication in Journal of Neuroradiology from Istanbul team. My friend and colleague Kublai Aydin did a very nice drawing and published the stentotomy technique. But in his technique, maybe I can show you from my phone. Just a second. Just a second. If I have a little bit time, I will show you the drawing. There is a drawing from the about the braided stents. It's like this. Just a second. It's from the publication of Kublai Aydin. If you had any problem with your stent, it's a braided stent or laser cut stent, then you need to go inside the stent. In this paper, it was a snare and it was placed inside the stent. And then you need to go with the second wire and second microcatheter from outside of the stent to inside, and then go to the snare. And then just snare it and take out the stent with the wire and the snare all together. It was a technique. In Kazakhstan, we have no snares. That's why we are using solitaire stent. We are going with the 21 microcatheter inside the stent. And then we are going with the second microcatheter. Usually it's a 17 microcatheter and with the Chikai black micro wire, we are going from outside of the stent to inside. At this time, we are opening a solitaire stent inside the first stent and then going with wire inside the solitaire and catching the wire with the solitaire and taking out both microcatheters at the same time. It's a very good technique for the stentectomy, and I learned some tips and tricks from René Chapeau. He's my friend from Essen, Germany. And till this time, we did this technique more than 20 times, I think. And in some cases, like a coronary stent was withdrawn and both Aclinoflex stent, we took it out. It was just solitaire placed inside the stent and just pulled it out. And in most of the cases, it's also very effective, and it's possible to take the thrombus with the stent inside.
Thank you. Thank you.
Thank you, Professor Rick. Probably we hear the last question, Professor Dr. Biswas.
Thank you, Sensei. Just two questions. I have missed Haraguchi Sensei's lecture. So I have one question to Kenichi Haraguchi Sensei and one question to our last speaker, if you allow. Can I proceed?
Yes, please ask.
My first question to Kenichi Haraguchi Sensei, that is for the transradial intervention. As a junior hybrid neurovascular surgeon, what should be the technical tips to go with the procedure like coiling transradially, apart from the diagnostic one? This is number one to Haraguchi Sensei. And number two question is to our second sensei, that for intracranial stenosis treatment, like the paracranial segment of the ICA, is there any role of embolic protection device with balloon occlusion?
Can I answer?
Thank you. The first question, Professor
Yes.
Haraguchi.
So you mean the especially for coiling?
Coiling, yeah.
Yeah. I asking the tips
Yeah,
for the
exactly.
coiling transradial approach.
Transradial approach, yeah.
So for coiling, I think there is more risk of rupture comparing to the flow divert deployment or wave deployment. So I think that the balloon is necessary. So you have to use more than 6 French guiding system using both of microcatheter and balloon catheter. So to do so, we insert the 6 French guiding system transradially and use that, and also coaxially use the 6 French distal access catheter. Yeah, and that's the tips. I think you have to use both of balloon and microcatheter.
So we suggest to use DAC all the time, distal access catheter all the time.
All the time. Yes.
Okay. Thank you, Sensei.
Okay, thank you for the question. And from the stenting of the V1 segment of the vertebral artery, if you have this experience for the vertebral artery, we never use distal protection device because the plaque in vertebral artery is different than plaque in carotid artery. In carotid system, in external carotid system, we all the time use filter. It's a distal protection. In vertebral basilar system, there is no protection, and in cavernous supraclinoid, paraclinoid segments, there is no need for protection device, and the plaque usually like in vertebral basilar system.
Okay, Sensei. Just one subsequent questions. For the extracranial segment, though it's not your topic, but just out of curiosity, like the cervical segment of the IC stenosis or the just at the origin there is stenosis, do you use balloon and embolic protection device at the same time or just embolic protection device?
Fortunately or unfortunately, in Kazakhstan, we have no balloon guiding catheters.
Okay.
And the MOMA device was withdrawn from the market. And nowadays we're using just a spider protection, or there is a pronder protection device from Lepo Medical. It's very nice, yes.
Okay. Thank you, Sensei. Thank you very much.
Thank you.
Thank you, Biswas, for the question. And I think we come to the end of today's session. With that, I thank both our speaker, Professor Haraguchi and Professor 𝑽𝒐𝒊𝒃. And before we end, probably we hear the closing remark from Professor Yoko Kato. Professor.
So thank you very much for two speakers and also the audience. So I think Professor Haraguchi, Kenichi Haraguchi, showed us a very nice transradial approach, especially peripheral radial artery is one of the I think a future for endovascular treatments. So and also the Inzilti, your skill is wonderful, I think. But sometimes we encounter the re-stenosis, or the recently we have a dolichoectasia of the vaginality. So the patient has 3 times the bleeding. So I think such the very difficult case. I think it's still unknown, and how we can treat such a very very difficult case. But I think Kazakhstan is very far advanced in it, especially in endovascular. So that we learned a lot from you. And also the Terik. So nice to see you again. So you're the open surgeon, I know, but I think you have a great knowledge about endovascular treatment. So that we learned a lot today. Thank you so much. This is the first webinar.
Thank you, Professor Jakarto. And with that, we end today's seminar. Thank you for all the audience and speaker. See you again. Bye-bye, everyone.
Bye-bye, everyone.
Bye-bye.
Hey, John.